Assistant Professor Nutcha Pinjaroen. She's from Radiology Department, Chulalongkorn University. Please welcome.
Thank you, Dr. Vipusit, and good morning, everybody. First, I would like to thank the organizing committee for inviting me. It's my privilege to standing here and share my experience and how can we work together, a surgeon and also the interventional radiologist, to push the patient to the curative treatment. So we work closely with the hepatobiliary surgeon in preoperative treatment, also intraoperative procedure, as well as postoperative complication and tumor recurrence. So all this together, today I would like to focus about the preoperative procedure that we can help the surgeon with the outcome of the surgery. So I would like to divide into three tumor types: HCC, cholangiocarcinoma, and colorectal liver metastasis, because each tumor differ in strategy of treatment and also IR procedure preoperatively. For HCC, we can use TACE, Y-90 or ablation for bridging to surgery or to transplantation. And for downsizing, TACE, Y-90 or HIC. And for FLR augmentation, usually we do TACE plus PVE. And nowadays there is more popularity of hepatic venous deprivation. And also the other method is Y-90 radioembolization. For cholangiocarcinoma, if the patient presents with obstructive jaundice, usually we require biliary drainage preoperatively, and then maybe downsizing or downsizing with systemic chemotherapy. With or without that, and then sometimes Y-90 can be a preoperative treatment for localized disease or intrahepatic cholangiocarcinoma as well. And for liver augmentation, PVE or hepatic venous deprivation with biliary drainage is usually required. For colorectal liver metastasis, systemic treatment is the mandatory to downsizing, downstaging the tumor first, and then with the curative treatment, we could do the PVE and then resection, two-stage hepatectomy, or resection with ablation. So I would like to start with the FLR augmentation before the liver surgery. So nowadays, non-operative method, we have three kinds. First is portal vein embolization, which is very well known and been practicing worldwide. We have to wait around 3 to 6 weeks after PVE before putting the patient to the surgery table. Technical success rate is very high, over 95%, but the cost of preventing subsequent liver resection mostly from tumor progression. And when compared to liver venous deprivation, we have to embolize not only portal vein, but also the hepatic vein embolization as well. So theoretically, it's more technical challenging than PVE because we have to embolize two venous system, and with the hepatic vein, we need a bigger, larger embolic material device. But the result should be can create more rapid and more powerful FLR hypertrophy when compared to PVE. But this is small caution when the patient had the borderline portal pressure, especially in chronic liver disease, HCC patient, because if you measure the portal pressure after the hepatic venous embolization, usually the numbers goes up about 4 millimeters mercury. And the last option is not only for the FLR augmentation, but also in the same time tumor control with the Y-90 radioembolization or Y-90 radiation lobectomy. So with the Y-90, we can tumor downsizing plus FLR augmentation, but the surgeon has to wait a little longer, around 3 to 6 months before bringing the patient to the surgery. The limitation is the cost of the treatment is more expensive and less accessible than portal vein embolization, but I recommend Y-90 when you have the patient with large tumor burden and equivocal resectability at the beginning, also the patient with borderline performance status, and also the patient with advanced age. First, for portal vein embolization, usually 20, 30, 40% is kind of like, you all know, I know that. But for cholangiocarcinoma, I would like to emphasize that with biliary obstruction, you need at least 40%. And if you plan to do bile duct resection or vascular reconstruction, you may need more than that, more than 50% of the FLR. And also some patient with the previous heavily chemotherapy treatment and also diabetes, you may not get very good hypertrophy even after PVE. And not only the volume, I think you all know that the function has plays role in the function of the FLR as well. So ICG usually consider in the case that kind of aggressive surgery is needed. And the strategy of PVE for each tumor is different. For HCC, we have to start with TACE to control the tumor and before bringing the patient to PVE. For cholangiocarcinoma, you may need biliary drainage. And for colorectal liver metastasis, if you plan to do two-stage hepatectomy, first you need to clear the first stage with either resection or ablation. This is the very simple, straightforward case of the PVE for cholangiocarcinoma. We will bring the patient for test first, blocking hepatic artery and tumor feeder. Otherwise, if you do portal vein embolization without embolizing the hepatic artery will get hypertrophy after PVE, and then the tumor will get progression. So that's why the reason we have to do TACE before portal vein embolization. The time interval between TACE and PVE could be around 2 to 4 weeks. And then after PVE, we wait another 4 weeks before evaluate the FLR again. And for this strategy, even the small or borderline medium-sized tumor, you can ensure that you can get the anatomical resection or hemihepatectomy to get all the cover margin and prevents the risk of the segmental or lobar recurrence after surgery. And with case that borderline resectability at the beginning, so don't give up just easily. Sometimes if you're not sure that this kind of tumor, the patient has 3 masses in the right and in the left lobe, size between 7 on the segment 4 and also up to 14 centimeters in the right side. This patient come to our center in 2021. By that time, the immunotherapy is not popular yet in Thailand. So the treatment we offer to the patient is try to downstage to resection with either TACE with PVE or Y-90. And then the surgeon advised TACE plus minus PVE and then right disectionectomy, and the patient agree with the treatment plan. When you plan the treatment like this, we have to do it one by one and re-evaluate the patient in every step of the treatment if the patient tolerate the treatment or not. So first we start with the first TACE, try to embolize the larger mass as much as possible. And then for the second, we bring the patient on follow-up and the patient doing well, the patient can tolerate the first TACE. Then we bring the patient back to the second TACE to the smaller mass in the segment 4. And then after we complete the embolization of the tumor within 2 sessions of TACE, the surgeon measure FLR for disectionectomy about 40%, but they said they need more, so they consult for PVE plus S4 embolization. And then 2 weeks after second TACE, we bring the patient to do right portal vein embolization plus S4. And the FLR after PVE is 46%. Then the patient took the patient to surgery, and the pathology come moderate deep HCC, free all resection margin with the microvascular invasion. And now the patient live with the recurrence-free disease over 4 years. The case like this, if you cannot surgery at the beginning, maybe we can help us to bring the patient to the curative resection. So like TACE, PVE can not always, but still can provide anatomical resection for initially unresectable patient, and the patient can have long-term survival with this strategy of treatment. The other tumor is more complex, carcinoma, because usually the patient come with biliary obstruction, and we need to drain when the patient had the bilirubin above 5 millimeters, and also when the patient had cholangitis or the patient had dilated bile duct in the FLR. And then If you need the more volume, more than 40 or more than 50% of the FLR, we consider portal vein embolization. And usually before bringing the patient to the definite resection, TB level should be less than 2. This is the recommendation from the Japanese articles, and which is quite similar to our practice in Thailand. This is the review of the 61 patients of cholangiocarcinoma in our hospital from 2014 to 2019. And 98% require biliary drainage, and PVE require in almost 80%. And from this series, we got resectability rate almost 60%. And when you compare when the patient can underwent resection and cannot underwent resection, you can see that median OS is significantly better if you can bring the patient to definite resection. We analyzed the biliary level before PVE, before biliary, then and we found that the pre-PVE and pre-treatment biliary level doesn't matter. The only matter to the post-operative hepatic insufficiency is the preoperative T-biliary level that should be less than 2.2. So from this, all the data, we encourage you to bring the cholangiocarcinoma patient, try to convert them to surgical resection to get longer survival. And also, if you have the inadequate FLR, you can consult for portal vein embolization, and the T-biliary level before operation should be less than 2.2. And when you look at the PVE techniques for the cholangiocarcinoma, is more complex, more complicated than just straightforward right portal vein embolization. Like for extended right hepatectomy or right trisectionectomy, usually sometimes we require S4 embolization. And for the left extended hepatectomy, sometimes we require anterior portal vein embolization plus left portal vein embolization. So when compare cholangiocarcinoma with other tumors, colorectal liver mets and HCC, the resectability rate of the cholangiocarcinoma is the worst one after PVE. Mostly because of tumor progression, but the other one is because of the tumor location. Usually for perihilar cholangiocarcinoma, the tumor is in the center or in between two lobes. So what we are doing embolization is regarding the surgical plan. So the surgeon will inform us specifically what kind of operation they will do and what kind of portal vein embolization, what the extent of portal vein embolization they require. We will communicate this closely to make sure that our embolization plan match to the surgical treatment plan. Like for if the surgeon plan to do right, do we need to do S4 embolization? Or if the surgeon plan to resect left, do we need to do right anterior portal vein embolization? And the other thing is about the last thing I would like to talk about the PVE is the other strategy of the colorectal liver metastasis, the two-stage hepatectomy. So the two-stage hepatectomy has been described since 2000. And the strategy is that for multiple colorectal liver mets, you clear the first stage on the left lobe with resection or RFA, and then you bring the patient to portal vein embolization. And after that, if the disease is controlled, you bring the patient for the second time operation of the right hepatectomy. And all this, you need a systemic treatment to control downstaging, downsizing the tumor. This is an example of the 69 years old multiple bilobar liver metastasis from rectal cancer. First, we do first stage surgery with resection to the left lobe. And then we do right portal vein embolization. And after that, the right hepatectomy, and the patient has OS about 5 years without any hepatic recurrence, and the patient died of the extrahepatic disease. You can see that this strategy can provide patient long-term survival, but not all the patients that can follow through this strategy. Only around like 60 to 90% can complete the second stage surgery. So if the patient had the tumor progression along the way, so maybe we cannot finish all this treatment strategy. And the outcome, if the patient can underwent the two-stage hepatectomy, the 5-year survival is around 30 to 60%, which is very impressive for multiple colorectal liver metastasis. And also, all this, we need at least like 3 to 6 months in order to like plan all this treatment and do step by step. And we need the baseline and also follow-up imaging all the cost of the treatment to evaluate the next step of the procedure. And this is the other simple way for multiple colorectal liver metastasis is the combination of ablation and resection. So for combination ablation and resection, mainly for the parenchymal sparing surgery, which means we can help you spare the healthy liver tissue as many as possible. For the superficial lesion, you can resect it or laparoscopically or open resection. And for the deep-seated tumor, we can help control the tumor with the curative ablation. So the aim is to destroy the tumor while preserve much healthy tissue as possible. And this is an example that for the superficial lesion, the surgeon do with resection, and at the same time, we help the surgeon do RFA for the deep-seated tumor. And nowadays, there is the problem about the vanishing tumor, and also when you can downsizing the tumor with the chemotherapy. Sometimes you cannot see it on the CT scan, but with the Primovis or EOB MRI, you can clearly see the tumor border, and with that imaging, we can use that image to fuse with an ultrasound to locate the tumor. And we can use this image modality to guide the ablation of the sub-centimeter nodule. So for colorectal liver metastasis, if you plan to do surgery or ablation, I recommend you to use the Primovis MRI to evaluate the small nodules and also the vanishing tumor. So we can make sure that we get all the tumor residual treated. And the last one is about the Y-90 radioembolization. Like I said, that you may need a little bit longer, 3 to 6 months before bringing the patient to the surgery. But it's very helpful when you are not certain that this patient is resectable or not from the beginning. And the other one is about the hepatic venous deprivation on the literature. They prove that hepatic venous deprivation can increase the FLR volume and also FLR function when compared to PVE. But then there's some limitation because more technical challenging. Not every IR can perform this procedure, and also there will be a cost of the larger embolic device, which is more expensive. So in our center, usually we approach it more gentle way. So after PVE, if the patient still had inadequate FLR, maybe we bring the patient to the subsequent hepatic vein embolization. And the last choice is the Y-90 radioembolization. For Y-90 radiation lobectomy, Y-90 can induce contralateral lobe hypertrophy and can bring the patient to curative resection. So if you're not sure is the patient resectable at the beginning, you can downsizing and also at the same time increase FLR with Y-90. And this is the case that we resect the patient after Y-90, and the patient had a long-term survival without systemic treatment, almost 7 years. And right now, nowadays, we have the personalized dosimetry. So our data from January to September 2024, last year, we can downsizing the patient to the resection as high as 33%. Actually, downsizing to resectable cases around 44%, but the patient agreed to resection only 6 cases, around 33%. And this is the 6th case that we can resect from the Y-90 last year. You can see that we can resect even the elderly patient or the large size tumor. And the problem of the Y-90 is that sometimes with the large size tumor, there will be a higher lung shunt. But if you can resect the patient, you can expect long-term survival. 3-year survival is as high as 86%. And this is our data, 9 cases that we resect from our center. Only 2 cases that present the disease recurrence. One is an extrahepatic recurrence, and one is a bone metastasis. So the local control of the liver disease is very good for the Y-90 radiation lobectomy followed by hepatic resection. The problem is not every cases can do Y-90 because of it's expensive and also high lung shunt. But nowadays, when the case that had high lung shunt, we start with systemic treatment, Atezolbev, and then most of the time can decrease lung shunt down, and then we bring the patient to Y-90 and then to the resection if the possible. So with the new emerging treatment and new modalities, we can treat what we cannot treat before with multimodality treatment. So we can help the surgeon expand curative approach, and also we can take care intraoperative procedure together and also postoperative recurrence as well. So thank you for your attention.